I think we're gonna. Hello? That's not on. We're gonna get started. Morning. Before we begin today's business, I just wanted to let everybody know that we should recognize National Correctional Workers Week. As the board has said many times over many years, that the staff in the New York City jails have the most challenging jobs in the city. So we want to thank the correction officers for their service to the city, for their exceptional work and daily commitment to improving our city's jails, public safety in those jails. We'll begin the scheduled business by voting on the draft April 20th, 2018 board minutes, which board members have already seen. Is there a motion? Is there a second? Seconded. Okay, any comments, questions, changes? All in favor? Aye. Yep, thank you. Motion is passed. Next, we'll talk about healthcare access and the action plan. Martha?
Sure. Bennett's going to help me. Good morning. Ensuring the delivery of correctional health and mental health services in compliance with the minimum standards is a critical part of the board's mission. Access is a fundamental policy and principle of the standards and of all nationally recognized jail standards. For the past 2 years, to monitor compliance with its minimum standards, BOC worked closely with CHS and DOC on efforts to track and report health and mental health services and access outcomes. The board required Correctional Health to produce a monthly access report monitoring each month's approximately 55,000 scheduled health and mental health visits, 10,000 sick call visits, 4,000 health intakes, and various other health encounters at each of the 12 facilities and overall. The monthly access reports represent the most comprehensive, ongoing reporting on health and mental health care access in jails nationally. The report was improved in the spring of 2017 with the goal of identification of underlying barriers to access. Access to health and mental health care in New York City jails has been discussed at 8 public board meetings since January 2016 and is the subject of BOC staff monitoring in the jails. During these public discussions, board members have repeatedly cited their concerns about issues related to access to care, including lockdowns, production, escorting, transportation to Bellevue and Elmhurst hospitals, sick call, and specialty clinic policies. Discussions on these issues have repeatedly confronted the need for improved tracking and outcomes related to the minimum standards. This information is needed to effectively minimize barriers and improve access to care via measurable reform. At the board's February 2017 meeting a year ago, DOC and CHS announced their development of an action plan to improve access. In June 2017, DOC and CHS presented the board with an action plan that included independent and joint strategies related to staffing, scheduling, transportation, tracking people in custody, and communication. Joint efforts by DOC and CHS included just 2 pilot initiatives. 1, a cohort housing initiative to reduce the need for escorts for patients with similar health needs, and 2, a coordinated patient scheduling initiative intended to reduce overscheduling and scheduling conflicts. CHS and DOC report that the cohort housing initiative has been successful in achieving many of the goals of the pilot, but further coordination between DOC and CHS is necessary to understand why all patients eligible for the housing referred by CHS were not placed in those units. and whether there's room for improvement or expansion of the approach. In January 2018, CHS and DOC ended their coordinated patient scheduling pilot, finding little to no impact on targeted outcomes because they determined there were not enough scheduling conflicts to be a significant barrier to access. The indicators in the access report did not change during or after the action plan. Creation of the Joint Action Plan was a step forward, and now we are hopefully at another turning point. Today, we released a summary of the monthly access reports from the last 6 months of 2017. I want to thank Heather Burgess, Nashla Ravas-Salas, and Emily Turner for all of their work on this. The summary shows, first off, that there were just over 340,000 services that were scheduled during the 6-month period. 41% of those scheduled services were for mental health services. The next highest categories were nursing, social work, and medical appointments, respectively 24%, 11%, and 11%. 79% of services scheduled during this period were completed. This means that for 79% of scheduled appointments, the patient either saw a clinician or the patient refused the service and told the clinician they did not want the scheduled service. 93% of completed services were seen by a clinician, and 7%, or close to 20,000 appointments during this period, were refused. Completion rates varied by facility, ranging from a 67% low overall completion rate at VCBC to a 92% completion rate at NIC. Completion rates varied more when analyzed by facility and service category. Completion rates for medical and dental services in particular varied widely across facilities. Medical services ranged from a low 54% completion rate at AMKC to a 98% completion rate at MDC. Dental and oral surgery completion rates ranged from 48% low at VCBC to 84% at RNDC. Almost half of completed specialty clinic off-island and 31% of completed on-island specialty clinic appointments involved a patient refusing services. Off-island services are reserved for advanced surgeries, procedures, and appointments that cannot be carried out on Rikers Island. People in custody and jail staff report that high rates of patient refusals for off-island specialty clinic appointments are due to lengthy wait times, overbooking, waiting area conditions, and transportation challenges. Just over a fifth of all scheduled services were not completed. Dental and oral surgery appointments, mental health appointments, and on-island specialty clinic services were the least likely to be completed, with non-completion rates of 32%, 29%, and 27% respectively. The highest number of missed appointments occurred in mental health services. Close to 40,000 mental health appointments were missed in this 6-month time period. This is over 5 times as many missed appointments as the next highest service categories with missed appointments. The main reason that patients missed appointments was because the patient was not produced by the Department of Correction. Almost 70% of all missed appointments were due to DOC not producing the person to the clinician. DOC non-production was the top reason for missed appointments each month studied and across all service categories. CHS does not report the detailed reasons for non-production, as these reasons are not always known to clinical staff. We all should better understand if failure to produce a patient is because of an alarm, because of a lockdown, or because the patient was produced due to a correction staff escort shortage, for example. We need DOC to start tracking and reporting on the reasons for non-production in a coordinated way. After DOC non-production, the next most common reason for non-completion were that the scheduled services conflicted with a patient's court date. That was 17% of missed appointments. And then the most common next reason was that the service was rescheduled by CHS. So 15% of missed appointments are due to rescheduling. The board's summary report provides 10 recommendations for improving access to care. Based on the data findings, the recommendations seek to address barriers to DOC production, improve completion rates for mental health services, and increase access to on- and off-island specialty clinics. Additionally, we make recommendations to fill in key gaps in monitoring compliance with minimum standards, including setting benchmarks for access to care and developing new tracking and reporting on sick call, intake, timeliness of service delivery, and substance use treatment. I'm going to, I think, open it to Correctional Health and DOC. So with that, Correctional Health and DOC, if you would come up and present on your ongoing and new initiatives to improve access to care. The board wants to know about how this will work and how this will improve access, and when and how you project that the initiatives you're doing now or in the future will impact and will show an increase in the access numbers.
Good morning. First of all, my name is Dr. Nicole Adams. I'm the Deputy Commissioner for Health Affairs for the Department of Correction. We would like to thank the board for taking interest in this very serious topic, which is access to health care. And we, Health and Hospitals and the Department of Correction, also take that very seriously. We take it so seriously that in addition to the pilots that we had discussed in our collaborative plan, we've also taken other initiatives based on our discussions that's happening daily at the facility level. We didn't need to wait a month, we didn't need to wait a week, we didn't need to wait till the next board hearing to understand that we needed to take action in a way that was urgent, in a way that was significant. So to that end, we've, on our own, in addition to the pilots, we've done several other things to help enhance access to care in real time, every day. So one of the things that happens daily is we do have a daily huddle where we discuss the individuals that must be produced on that day. As a team, we discuss how to get people down, what might be barriers to care that specific day, and we take action accordingly. So it might mean we have to assign additional staff, additional escorts. We might need to ask another provider to come from another facility. We might need to look at how service provision is happening that day and reallocate resources to make sure that it's enhanced. So mental health, or access to mental health care, for example, that the board referenced in their report at AMKC, was something that we too were very concerned about. So to that end, in a collaborative effort, we actually opened an additional mini clinic at AMKC, and we were actually able to service like 24 housing areas in one day, which really, in that one initiative, was able to kind of address making sure people had access to resources in a very meaningful way. In addition, we've had a lot of stuff that we're working on together. We actually, for 2 months, we piloted a study where we talked about individuals that were referred for mental health services actually being seen the same day, right in intake, even before they were housed. We found that was something we also were able to use in real time to address people getting access to mental health care in a meaningful way. That's a pilot we're looking at, a better way to kind of implement operationally what's the best way to execute it to help individuals get that service. In our own data discussions and facility level discussions, we also realized one of the reasons why people are not coming down to get services is because they're refusing in the housing area. In conjunction with Health and Hospital, we're looking at ways that we can use teleconferencing model to help allow people to get educated by medical providers in the housing area if they're refusing to come down in real time, because we recognize that for a while we thought it was a scheduling conflict that was the reason why, but what we know now from all of our discussions and collaborations is that a lot of people are refusing in the housing area. The most significant number are refusing there. But people that are refusing in the housing area still need to see a physician. They need to be educated about the importance of that appointment. So one of the things that we're exploring is how can we use telehealth in a more meaningful way to help make sure those individuals are better educated about why they need their service appointment and come down to the clinic. When we're looking at off-island specialty clinic, one of the things that our daily collaborative discussions revealed to us is that sometimes with the number of appointments scheduled, it's hard to hold all of those individuals safely in a hospital setting. So proactively, we reached out to SCOC to get approval to build additional holding area space at Bellevue Hospital. We received that approval from SCOC. We're moving forward with building that additional space so that we can hold more individuals so they can be seen and wait safely until their service can be provided to them while they're at Bellevue. One more, I feel like we've done lots of stuff, but these are just kind of the highlights that I'm covering right now. One last thing I'd like to say is that all of us sat down, and I'm saying all of us meaning Health and Hospitals and the Department of Correction, we decided that we really needed to have a monthly collaboration meeting because although we're having daily discussions at the facility level, we wanted to demonstrate that there is executive leadership support and at every level that we're all very vested in this initiative. So monthly we're now having meetings where we meet with the actual clinic staff, both security and medical, where we talk about what are we prioritizing, what's the best way to make sure we get access to care done in a timely fashion. And we feel like that it's really been a successful way in helping us address this issue in a meaningful and timely way. Oh, wait, one more thing. And then I had also talked about how it's really become a priority. Also, when we're talking about the numbers of individuals that are produced, we have a monthly leadership meeting in the Department of Correction, and it has actually become something that every single facility is asked to report on to every level of leadership. How are you enhancing access to care at your specific facility? How are your services being impacted? Are you dedicating officers? Are you making sure that staff's available to do it? So it's something that we once again just want to thank the board for supporting us in the ability to work together to really address this very important issue.
All right, good morning, everyone. My first time here, so just bear with me, all right? This is one of those times where I got to tell you that, I agree with Dr. Adams. The approach that we have now in all the jails is real time. I'm sorry, sir. Carlos Castellanos, I'm the Director of Operations for CHS. Thank you. As I said, I do agree with Dr. Adams. The jail approach that we have nowadays has opened real-time communication in all the jails in the mornings. And based on those meetings that we have every morning, daily huddles, we're able to discuss problems on a daily basis so that we could effectively provide the services the day off. So I think the real-time communication that's taking place has come a long way. We call it more like a jail-based approach where DOC in the clinics, medical staff will come and get together and talk about all the staffing levels or any problems that are happening at that moment to be able to provide the services at one particular jail. So I do agree with everything that you said. Anything you want to add? I'm sorry, I will. You want to ask something? Sure.
Hi, my name is Ben Farber, Director of Planning and Analysis for Correctional Health Services. Just to add to Carlos and Dr. Adams, I think some of the success we experienced with the clinical cohort evaluation is a testament to the collaboration between both organizations. When you look at the data on a housing area level focused on specific cohorts of people, I think the success was excellent. For the evaluation period for the clinical cohorts, 42 to 53% of eligible patients were housed in a cohort, and the equivalent occupancy rate was 95% for that range of time. So from a service delivery perspective and a collaboration perspective, I think that shows the effort that we're putting in collaborating is definitely worthwhile.
Very good. Any board questions or comments?
I have a question. Could you give us a little more insight into mental health patients? Because I think in many ways they're special and very important. So.
I like those words, special and very important. Agreed. If we don't address mental health needs, we find that individuals really that are very vulnerable are, have greater difficulty during the time of their incarceration. So in recognizing the importance of getting individuals with mental health needs, so like your report had suggested, AMKC is our largest jail. So when we see deficits there, we recognize the importance of really making sure those individuals are getting access to care and treatment. So we can have kind of extra special meetings about AMKC. That's where that decision to create an additional mini clinic happened, which is what we already implemented. It's opened, it's functioning, but it's also where we kind of looked at how can we make sure that those individuals that are seen upon intake are being seen by a mental health provider as quickly as possible. And we recognize that if we're able to kind of capture and work with them right in intake, that we're able to make sure that they're getting access to care in a more meaningful way. Dr. McDonald, do you want to add?
Morning, Ross McDonald. So I just also want to keep in mind that these are complex systems, and behind all these numbers are differences in workflow. So when you look at mental health in particular, I would keep in mind the very high standards that we hold ourselves to in New York City for mental health care service delivery, where our standard is for a stat referral from intake, that we see that patient within 24 hours, and for a routine referral that we see that patient within 72 hours. And we have extensive metrics to measure our success in those efforts. So some of the numbers that you see here are reflections of efforts in that area. So for example, in those first 3 days, there are a lot of things that happens to someone in the course of their jail stay. They may be transferred to another facility. They may have a lawyer visit, a court visit, a family visit. But we're single-mindedly trying to get access to them in those first 3 days. And that actually generates a lot of scheduled appointments, which may or may not be completed in that day, but it allows us to have a high rates of success at completing those appointments within the 72-hour time period. So when you compare, for example, from jail to jail or from service to service, it's important to keep in mind the workflow differences and the population differences that are behind those numbers. And in particular, the mental health numbers where you see higher rates of visits scheduled that are not completed. I really think that's a reflection of our single-minded efforts to get people early on in their jail stay rather than it is a marker of lack of access.
So what proportion of the mental health appointments are about the first 1 to 3 days? Because I was under the impression the mental health appointments were covering all mental health appointments scheduled.
That's correct. But as you know, much of the work in jail, because of the rapid turnover, is driven by the intake population. So that first 3 days is an essential period of time that we focus on, whereas people who've been with us for months will stabilize as they would in the community to where they would need an appointment, say, every month or so for most patients.
So do you have a sense of those folks who miss the mental health, what percentage of them are missed based on the initial referral, or is it mostly it's a follow-up appointment that they weren't produced?
Yeah, so we absolutely. I mean, we have quality metrics, certainly in the mental health realm. Many of them are by federal stipulation under Brad H, and we have ongoing monitoring and reporting of all those details of our service delivery. So, you know, there are many different ways to look at a healthcare delivery service. Quality metrics are an important one, and there are many metrics that live behind this that is part of our day-to-day management of the healthcare service.
Right.
I want to thank the Department of Correction and Health and Hospitals for coming up today. I want to fundamentally support the findings of the Board of Correction staff. I find it disappointing, and I find their recommendations on point and critically important. The monitoring of and the provision of health care in the New York City jails requires that there be a common data system between the Department of Correction and the Health and Hospitals, which begins, in which data can be entered in 2 ways. 1, a person requesting care, as in sick call, and 2, when you initiate a referral to mental health or follow-up to yourselves or to a specialty care. And that is not what's going on. And in fact, the data sets that the Department of Correction and the Health and Hospitals have barely any relationship to each other, or off by factors of 100%. in terms of what is actually going on. It is the wrong, I think it's not a good idea to think of the goal of clinical care in a jail system to be completion, where completion means refusal. When a person has been waiting, and your staff, Ross, has referred them to Bellevue, and they're waiting in the receiving room where they've been waiting for 4 hours on a morning, and are told at 9 o'clock that the bus is going to be leaving in about 15 minutes, but I don't know if it's going to actually get there in time to the appointment, that's called a refusal, and that's a completion. That's not right. Every clinical encounter that's initiated by you or required by or requested by a person should be the element of a database, and the end of that is when the care takes place. And that evaluation of that care includes, as you describe, whether the care is done in a timely manner. I understand that you say you have data on that, but I also understand that you are not providing that data to the board when we ask for it, and I really request that you do. I also think that it is critical that the Department of Correction and the Department of and Health and Hospitals work from the same database. This is a large healthcare system, hundreds of thousands of appointments a year, a lot of money that's being spent on this, and the city needs to know what's going on, and to meet our standards, you are required to have data that represents what I am talking about, an individual patient request or your individual referral, and that is not a difficult thing to do, but it is very, very important to do. Our recommendation that you study the reason for refusals is critical. The purpose, the goal of a correctional healthcare system is to get the problem with providing healthcare in jails is that it is difficult because of all the barriers that exist. But the answer is not to say this is the barrier to care. The answer is to change it. Now, you described, Dr. Adams, things that are being done. Obviously, based upon the data that we have, that you provided to us, there's a lot of work to do. So I want to strongly encourage the Department of Correction and Health and Hospitals to establish a fundamental database. I want to add one more thing to my comments, which is that in the Department of Correction and Health and Hospitals system here, when someone requests sick call, that information is provided to the Department of Correction, not to Health and Hospitals. I think that is a fundamental flaw in this system. You, Health and Hospitals, are relying on the Department of Correction to essentially get people to you, and you don't know who those people are. So when you receive a referral, when you receive someone in sick call, it's because the Department of Correction has decided to bring that person to you. As Dr. Adams described, getting everybody there on the same day is an accomplishment. So you don't know how long people are waiting. Now you've said to me, and we've had this discussion many times, that people make many appointments and don't show, and we don't know why it's going on. But your job is not to have the Department of Correction triage for you. I really strongly urge the departments to coordinate, create a single database, and for the initiation of sick call to be from a person to a sick call box, which is confidential, or if they're in a restrictive housing area and don't have access to a sick call box, to a member of the health staff who are visiting, and that there's no point that corrections only gets involved when you ask them to bring the person to you, and you record in your database every person who requests care. I understand how difficult this project is. It's extraordinarily difficult, and I understand how hard you all work to accomplish what is being accomplished. And I'm not questioning the quality, the quality that you claim, Ross, in terms of what's being delivered. And we can see great differences actually over the past several years in terms of some terrible lapses of care that were observed a number of years ago. But this stuff really matters. And as a point, as a demonstration of that, what really matters is that all these, having missed appointments in the first few days is not a good, is nothing to, is not the answer, making those appointments. And I think generally you do, and the proof is that there have been no suicides in New York City's jails for over 2 years. So this matters. What we're trying to do here, and I urge you to collaborate more effectively as required by the board standards. This is one of our requirements, and that a singular database be maintained from the point of patient request that goes directly to health and hospitals, and DOC's role is not to triage but to transport and to provide the escorts and to fix the problems as you described. Thank you.
Hi, Dr. Nadal, come on. You guys are doing God's work. We get it. I'm the oldest guy on the board in terms of tenure. I've been here 17 years. And continuity of mental health has always been really important to me. I think I speak for many of my colleagues, don't believe many people who are on Rikers Island should be there. And I think many of them suffer from mental health issues. Is this idea about FaceTime a real alternative that is acceptable to, the clinical community and to and to the people who have, grade H and the other monitoring folks? Is that an acceptable clinical approach if people don't come to appointments?
You're talking about telehealth encounters? Mm-hmm. Yeah. So,
specifically for mental health issues.
Yeah. So I think it is an accepted practice, and I think we really look to our patients and to our clinicians to answer that question. It's certainly not appropriate for every situation.
No, but I mean, we're talking about people who don't come to appointments, and I appreciate what Dr. Cohn is saying. I also appreciate that if people don't want to go to appointments, they're not going to go to appointments. But it seems to me, if you FaceTime them, or whatever term you want to use it, that you might be able to get a connection to talk to someone who needs assistance.
Yeah. Have you looked at the response to it? Has it led to people coming in person? That's my question.
Yeah, so we're just dipping our toes into the use of telehealth for this particular purpose, but I think the key is to use it in the right clinical scenario. And really, a lot of the refusal issues as it pertains to mental health are related to patients with lower levels of pathology. So people who may be on the borderline, people we may be worried about because of some symptoms that they showed, but not necessarily people who truly have a mental illness and don't want to think of themselves that way. So for that type of patient, it's often a great way to connect because it's a lower barrier to get us in front of the patient, to have that discussion, to make sure that it's not something that we're missing versus, say, a patient who's seriously mentally ill with active psychosis, where that modality is not really going to be appropriate.
We're all concerned about these folks. I know you are too, but it just seems intuitive that if it works and it's permissible, this same board has passed variances on psychotropic drugs and have listened carefully to what you and your predecessors have told us about getting people better. It just seems like this is a hill that could be climbed and there could be accomplishments here.
Yeah, I think.
Could you come back and talk to us again about this?
Sure, we're committed to using technology to deal with some of these problems.
Another question, just in line with Bobby's questions. Could you speak to that? In the system about the sick call list is managed by DOC, H&H doesn't know, and just speak to that system. And then how does that work with the daily huddles and the monthly huddles? How could you prioritize people that DOC only knows about and you don't know about?
Yeah. So I could just say, this is part of our on-the-ground collaboration, and we know how seriously our counterparts in correction take sick call. Oftentimes we have a back and forth about the priority of sick call versus follow-up appointments. From the health service, we often focus on follow-up appointments because it's patients that we know, we've identified who we need to see. Whereas the Department of Correction very seriously takes that obligation to provide daily access to sick call. So there's a constant back and forth on that issue that makes up a lot of the conversation in the huddles. And then also, I would just say to look to the absolute numbers. So the board standards on sick call are geared towards ensuring a very high level of access compared to what you'd see in other jail systems around the country. And in fact, what we see as a result of that are very high numbers of sick call encounters. And Bobby, as you mentioned, we've discussed before that we know from our clinical experience that our patients have easy access to the clinic through sick call and that they come very frequently. And that's true for individual patients. So it's not just about the patient who might have signed up and not come, but we know that the patients are coming on a very frequent basis and that the volume of those visits are large, and that our partners in DOC have that as a key priority of theirs every single day to ensure that access. So that's what we base that on.
I'd like to ask specifically the department because it's your responsibility here. As I've said, some of it I would change operationally, but you're responsible for production. And this is not a new project that you started working on last month. It's not a new project that you started working on this year. We've been raising these issues to you for several years with data. You've been aware of it since the department began. Certainly, you were aware of it for the past 50 years because it's been an issue and it's been a board standard since the 80s, since the 90s. So why is it so low? And why is there so much non-production? I understand you're working very hard and you work every day and you talk about it, but is there a lack of is there a lack of escorts? Is it the lockdowns? The number of lockdowns that are within the department is up dramatically. Not talking here now about the emergency, very urgent cases that H&H has said get to us during a lockdown. I'm talking about the large numbers of non-production. How are you? What plans do you have beyond what you've already done to fix it? Because the situation is not good right now.
So, Dr. Cohen, I think it would be really helpful for us to have an in-depth data discussion, because I think that one of the things we've learned through really looking and doing a deep dive into this work is that production is very complex and it's very nuanced. And it's hard to explain all of that quickly to anyone. I think it is important to know that although we are collecting data, and you had mentioned it's separate data, it drives the real-time work that we're doing. So that being said, what we know right now is that what's contributing the most to people not getting to the clinic to see their service is that they're refusing in the housing area. So it's not in the data set. We send data daily, weekly, and monthly to the board, to health and hospitals, to everyone. And also the report that's here only captures a 6-month period from July to December, I believe. I'd be interested in having that data discussion, looking at currently what things are, because we have metrics that we're measuring daily and talking about daily where we expect our facilities to produce at 80%, or we're expecting people to produce at 80% or better across every different service area. And we do have data that we're using to drive that discussion in our huddles and at our facility level. So I'd love to have that conversation. It's just you're going to need to see what we're looking at and what we're using to drive
So this is
decision
data that
making.
we've not been provided.
We've looked at it.
We have looked at it.
Yes, and we can get into the problems
Okay.
in those reports. The report that CHS uses, that the board uses, indicates that production is the main issue in missed appointments. Refusals is the main issue when it comes to off and on-island specialty clinics. Everything else, it relates to production.
So we're talking about what you're referring to is the verified refusals when somebody comes to the clinic and sits down in front of a provider and has a conversation. When I'm referring to refusals, I'm saying when we go to the housing area and we say, you have an appointment, you need to go to the clinic, and the person says, I don't want to go. And they don't have an opportunity to talk to a provider about, so those are the refusals I'm referring to, which is one of the reasons why we're having a discussion about, is there a way that we can use technology in a meaningful way so that the person that is refusing in the housing area has an opportunity to still have a conversation
So you're saying
with an actual medical
the
provider.
non-production numbers also includes refusals that are given to DOC. That's what you're saying.
Yes.
Yeah.
Is there any particular impediment to creating this common database between health and hospitals and the department? Can that be done easily, or is that really a problematic thing to accomplish?
I do think that that's somewhat problematic. We are independent entities, as we've discussed many times, and we have completely different workflows, and these data are reflections, in order to be usable to us, they are reflections of our different workflows. We use our electronic health record to collect the vast majority of the data, and it's a fundamentally different process than what DOC is tasked with, often on a paper process going into the housing areas. So I think that it's best to have two separate independent lenses at this issue, and the effort that would go into standardizing those definitions and workflows, I think, would not yield benefits. I would also just point out that there's very little external reference to compare any of these data to. So my concern is that you could spend a lot of time coming up with very common definitions and then have a data set that you would have nothing to compare to. So these data, I believe, are best used relativistically over time so that you can see patterns, you can see problems in particular areas, and that's how we use them.
I think that is, you can do better than that. The encounter begins when someone requests the care. You then decide whether, when to see the person based upon the request that you get. You don't even know who's requesting care right now, and that's not acceptable and I don't believe consistent with our standards. Additionally, however, would it be possible for the department and collectively with health and hospitals to agree on some benchmarks for what you're going to achieve in the next period on non-production that we can the data that you'll provide us that we can measure and timeframes for getting somewhere. A lot of the data that you're the stuff that you're describing, Ross, where you say that we actually are seeing these people, we're just not seeing them. We're seeing them multiple times, or this is all the stuff that we can understand. We have very we have good analysts. We have a strong research department, and we've asked for this kind of data from you, and I asked for you earlier this morning, and you said no, you're not going to give it to us. And this is administrative data. This is not clinical. This is not clinical data. You say this person needs to be seen in 2 weeks. Are they seen in 2 weeks? Right now, people are putting in sick calls, and that's the kind of data that we want to see. If you show us that's what's happening, and that the missed appointment for this person didn't affect the fact that they got to the appointment in the period that you wanted, that's okay, but you have to show us that. You can't. We really. That's an administrative data point that is not us getting involved in the chart. And in terms of really hope that with the department we could, you could give us benchmarks of, in each of these areas of what you're going to achieve, and work with us on that. And we can only report on data over some period of time. I don't think it's not fair to stand up and say, well, everything's better now than it was 6 months ago, when it hadn't changed in the last 6 months and the previous 6 months. That's not reasonable.
Let me make a suggestion. I've heard kind of both sides or multiple sides to this question. I think we ought to move on right now on this issue, but I do think it's a serious issue that needs to get addressed. So let us set aside some time offline where the department and correctional health and the board can have a discussion about this and maybe come to a point where we think we can move it forward.
We have to have this discussion, but the fact is that the board staff have been trying very, very, very hard to have productive meetings with the Department of Health and Department of Correction, Health and Hospitals on this area, and we have been frustrated.
Well, we'll move that.
So we hope to do better.
We'll move
in the
that
future.
forward. We'll move that forward. Thank you, everyone.
In having common data sets.
So the next topic is the two variances we have to address today. And before we get to the variances themselves, we're going to have the public comment on the variances. One variance would allow DOC to continue to place young adults in ESH, and the other would allow DOC to continue to operate the secure unit with limited lockout time in law library in the housing area. We'll begin the variance section of the meeting with public comment. We'll ask the speakers to limit their comments to the variances themselves and the 3 minutes. We'll have an additional public comment period at the end of the meeting to address other issues. The first speaker is Kelsey Diavila.
Hello, good morning. My name is Kelsey Diavila. I'm the Jail Services Social Worker at Brooklyn Defender Services. Excuse me. BDS condemns the department's continued use of enhanced supervision housing and secure for young adults. The board has long recognized the harms posed by isolation of young people, and you strictly excluded young adults aged 18 to 21 from ESH, even when the units were created. Yet for years, rather than moving towards compliance, the department has abused the variance request process and expanded the use of isolation for young people. Now, we urge the board to deny the department's request and force the department to finally eliminate the use of inhumane isolation of young adults in these units. BDS, countless other advocates, and impacted individuals have voiced our concerns with the department's practice in these units time and again. Yet these units are overly punitive in design and character. Isolation of this type is particularly dangerous for young people whose minds are still developing. The department fails to provide individualized assessments. The practice of restraining young people in these units to death during their out-of-cell time is especially inappropriate in the case of people who have not been convicted of any crime. Isolating young adults in ESH and secure is not an effective means to reducing violence, and the list goes on. These harmful practices humiliate young people who find themselves regularly exposed to the devastation of solitary confinement, precisely the harm which the board sought to protect. Again, this impact is counterproductive to the board's goals and undermines the safety and security of the department as a whole. If the board is to grant this variance request once again, we ask you to impose stricter limitations and additional safeguards around reviews and restraints. We ask that you hold DOC accountable for their inaction. Thank you.
Thank you. Next speaker is Umar Ali.
How you guys doing? Good morning. Thank you for getting my name right, by the way. My name is Umar Ali. I'm a social work intern with the Urban Justice Center, but I'm also a formerly incarcerated young person. Now, I haven't been in ESH, right, established well beyond my time, but I've seen ESH, I've talked to people in ESH, and when I was incarcerated, I dealt with solitary confinement and being shackled outside of my cell. I was shackled outside of my cell every time I was out of my cell, right? Now, I can stand here and I can tell you how harmful solitary is, but y'all know that. I can tell you how harmful being shackled is, but 3 minutes isn't enough time to do that justice, right? What I can tell you is that when I was shackled and sent to school, I didn't pay attention in school. For what? If the school was for me, I wouldn't have been shackled, right? There's nothing conducive to learning about being there in chains, and that's what this is. It's not a restraint desk, it's chains, right? And I can tell you how when I left, when I finished serving my times, I left angry. I left resentful. I left with a sense of hopelessness that when I went back to school, I wouldn't participate. I wouldn't be in my class because I had memories of being chained to, just chained, sitting in my chair and not being able to participate. How is that conducive to rehabilitation, right? ESH has 7 hours of out-of-cell time, right? But when they're in their cell, they're in solitary. When we take them out of their cell, we put them in a separate form of punishment in a program that's supposed to be beneficial for these young people, right? Now, I coach a basketball team, mostly gang-involved teens, right? They're heavily involved in violence and all kinds of other stuff. If I can find, me, a social work student, if I can find ways to de-escalate situations, to de-escalate violence, right, in a small context of kids who, if something happened, they would attack me. If I can find ways to do that without using chains, then there should be no excuse why the department is using chains. It's an inherently harmful process. It's not conducive to rehabilitation. It's not, especially in young people. Especially in young people. And I can speak to that because I was in that situation. There's not a lot of time left, so I'll leave it with one last thing. When I was being held, I had a friend who was being held at the same time. He was in chains every time he was out of his cell as well. I came out of it better. I'm here speaking in front of you. I'm a social work student. I'm an intern. I'm working, right? My friend is dead, right? My friend, I can't blame the chains for it, but he left incarceration a different person, right? So I agree, and it's going to be mentioned, I'm sure, at some point, that safety is paramount. Safety for correctional officers, safety for the civilians who work there, safety for the inmates, safety for everybody. But this is not the way to do it. This does not promote safety. Thank you.
Thank you very much. The last speaker is Al Craig.
Good morning. This is becoming like monotonous. We come here all the time, we talk about this variance. Listen, people, it might be harmful for people to be chained. I don't even dispute what you're saying. I'm not a doctor, I don't play one on TV. But you got to be realistic. There's certain things that we have to deal with, and that's safety and protecting people, right? If you don't come to jail, which most people that come to jail go through without being shackled, without being in punitive seg, without doing none of these things, most people. But if you choose to continue crime in jail, there should be a consequence. Let's not get ridiculous. A lot of you that come in here, come to my community in Brooklyn, and you walk down and you see a black guy like me, you're terrified. You're terrified because of you fear violence. You fear it. Then when the person comes to jail and they beat and assault and stab and slash, you get up here. When they prove what you think in the community is going to happen to you, it actually happens to someone. You come up here with this nonsense talking about nothing should be done. I mean, how ridiculous is this? Do you live in a bubble? Where do you live? Like I get it, you got a cause, and this is a hustle for many of you. And young man, I hear what you're saying. But if you don't come to jail and continue criminal activity, you won't ever, because most people don't do it. Most people come to jail, they're terrified, they do their bail, they get out in 50, 60 days, they go home, and that's it. It's the guy who cuts that guy. It's the guy that beats that guy. It's the guy that assaults an officer, who punches a clinician in the face. You come here and go, well, they should get over that. So if you have that traumatic experience, imagine a traumatic experience the person who got physically assaulted had, a person who's been exposed to AIDS and HIV because somebody threw urine and feces in their face. You're not concerned about that because it doesn't concern you. But the next time one of you people walk down the street and you see a black guy like me walk in front of you, and you get a little terrified, remember how you get up here and say, oh, well, you know, I hope I understand, because you don't really understand this. The hypocrisy is ridiculous. Stop it. Let's stop playing these games. Let's protect these young people that's coming to jail, that get caught up for a minute, and they come through here. Let's not let them go there with $1.50 in their face. That's what we talking about, because y'all never talk about that guy. Y'all talk about the mental anguish that the person who afflicted some kind of injury on somebody. We all come up here and talk about him, but we never talk about the victim, the one that suffers through his slashing. What about that mental anguish? What about how hard it is for him to go and walk the street and see that scar on his face? Don't blame us, blame yourself. Thank you.
Thank you, Mr. Craig. Now we'll start the process of addressing the variance itself. So on July 12th, 16, the board first granted variances for minimum standards 1-05B and 1-08F to allow the department to house 19 to 21-year-olds in enhanced supervision housing. In October 2016, the board approved an extension of the variance, allowing the department to house 18-year-olds in ESH. The board last renewed the young adult ESH variance on November 14th 2017, to expire on May 16, 2018. The department has asked the board to consider another 6-month renewal of the variance. They have additionally requested the board to amend the minimum standards to incorporate this variance permanently. The department believes that ESH is a vital housing option for the management of the most violent young adults. We will vote on the variance request here today and review the minimum standards in our ongoing restrictive housing process. Will the department please present the variance request? The board will then have an opportunity to discuss this variance prior to the vote.
Sir, just point of clarification, it's okay with you. I think that Chief Bingo is going to provide the variance request for ESH, but also we'll just have 2 small comments from our programming staff and DOE just to kind of highlight a couple of the changes we made before we go into the kind of discussion with the board. That's okay?
Yeah, that's fine.
Thank you.
Good morning.
Morning.
I'm Maxine Mingo, Acting Chief of the Department, and the New York City Department of Correction is requesting a 6-month limited variance renewal to Board of Corrections Minimum Standards 1-16C to house young adults 18 to 21-year-olds in enhanced supervision housing.
Good morning. My name is Nick Marinacci. I'm the Senior Executive Director of Youth Justice Education and Treatment Programs for the Department of Education. I'm here today just to present some data on the students who went through enhanced supervision units this year. This is not all the data is not everybody who went through ESH this year, but it's only the people who enrolled in school. And the data is as of April 9th. That's the most current data I have. So I'm going to, that's actually part of the data. So this year we've had 40 total students enrolled at ESH. 40 total students enrolled in ESH from September through April 9th. Just to compare that to other 18 to 21-year-old populations in the jail, there were 297 of the same age enrolled at GMDC, 103 enrolled in the GMDC Peace Center, 11 in Secure, this is the same time period, and 99 at EMTC. So I just want to bring up those numbers because I'm comparing, even though we're going to compare some percentages, the sample size of ESH is smaller, so that should have an impact in how you interpret the data. The active enrollment of students in ESH on April 9th was 11. Again, that's compared to GMDC was 82, EMTC 23, and so on. The average age for kids, for students who enrolled in ESH is 20.9 years old. I bring that up only because compulsory school ends in the school year, at the end of the school year in which you turn 21. So most of these students are at the end of their academic career. 53% of the students enrolled in ESH throughout the school year were identified as a student with a disability, having an individualized educational program. That is consistent with the rest of the students enrolled in East River Academy, which is about 54%. That's all of the other students in ERA. 95% of the students who enroll in school in ESH have what we call a gap in enrollment. That means that before they signed up for school on Rikers Island, they were dropped out of the DOE. And that is compared to 60% at GMDC. The reason for the difference is our school population in GMDC often comes right from RNDC, the younger guys who have to go to school, so they don't have that gap in enrollment. But it's consistent with EMTC, 87% have a gap in enrollment, GRVC Secure, 82%. The attendance rate, meaning the percent of time that students opt to come to school. Now remember, these are 18 to 21-year-old students, so each day they can choose whether or not to attend school. Their attendance in school is not compulsory. For ESH this year through April 9th, it was 42% average daily attendance. If you compare that to GMDC Maine, GMDC's average daily attendance was 35%. The Peace Center was 37%, Secure 30%, and EMTC 51%. So actually attendance at GMDC, ESH percentage-wise is really not significantly different than the other 18 to 21-year-old places where you have school. This is probably the most striking data point about ESH. 88% of the students demonstrated growth in math on the TABE exam. That's the test of adult basic education, which we give to everybody at East River Academy. 79% demonstrated growth in reading, compared to GMDC, where it was 46% in math and 53% in reading. The Peace Center, 40% in math and 53% in reading. Secure, 44% in math, 44% in reading. And EMTC, 40% math and 41% in reading. I actually asked the teachers, what they thought the difference was, and we have 2 teachers in that area at almost all times, and they just get a lot of individualized attention. So the students who come, even though their average daily attendance is 42%, they tend to perform fairly well after a certain time there. They get a lot of attention on the TABE exam. And as of April 1st, 2018, 3 out of the 3 students who took the task exam, which was formerly the GED exam, in ESH passed. Compared to last year in the same period, we had 2 students pass the exam. So as of between September and April 1st, we had 3 out of the 3 students who took the task exam who were in ESH passed it. Last year during that same time period, it was 2 out of 3 passed. So that's the data I have. I just wanted to present that data to the board. Yes, Judge.
Really appreciated the information you would provide us, so I'm really delighted that you've come here. I have a couple of questions. If I took down your data correctly, it would seem that the young people in Secure are not growing in math, are not growing in reading. I think you said 44% for them, where with enhanced supervision, 88 and 79%. And there's some of us that are of the opinion that Secure would appear, at least from all of the reporting we have, data collection and the like, that it's more therapeutic than the enhanced supervision. Do you have, so I'm very surprised by this data. Do you have any idea for why that would be? That the young people in Secure are not making the type of progress? Because that's even more individualized in Secure.
So I think part of it is that the Secure numbers sort of match the rest of the other numbers that I said. They're not that different. It's hard for us to say. I mean, again, we have 2 teachers there at all times, which I do think makes a difference. One of those teachers is particularly good wherever he's been. The kids do very well on the TABE. He's just a good math teacher, so I think that helps. It's hard to say. I think that for the time they're there, they get super individualized instruction. Like if you observe a class in ESH, it's less like a class and more like an intense tutoring session. And the teachers really rotate between. Whereas in Secure, a lot of times when I've observed it, it's only been, also the number's smaller. It's 1 or 2 students. It's hard for me to account for exactly why. I'd like to give credit to those teachers, but.
Yeah, of course. I have just a couple of other questions. Do you have an opinion based on the work that you're doing and your teachers are doing in enhanced supervision as to whether there's additional programming that could be offered to make this even more therapeutic and help the young people grow even more than at least what you're already accounting for, educational or not?
Absolutely. We always think that additional programming is going to help the students. You know, one of the things we did this year is to make sure we have more counseling occur there more often. And so I couldn't give you the exact numbers on how often we send the counselor there, but it's more than we had in the past. I know that. I think that one of the things that we have talked about in planning with the department for next year is making sure that the school day is even longer and working out so that next year we can work towards a 5.5-hour school day for everybody, regardless of the situation. The regulations call for 3 hours, and that's the minimum standard. And so that's something we have to work through in terms of security and location and other things. We do have an opportunity next year with the 16 and 17-year-olds moving off of Rikers that we will have some additional staff we may be able to deploy. So we're working with the department in planning right now for how can we get them. I know our goal next year is a full school day in every single area, meaning 5.5 hours. That's our goal, yes.
And have you tracked the young people who have gone to school in the adult enhanced supervision when they leave as to whether they continue to go to school after they leave?
Yes, we track all the students, the post-program attendance. That's one of our biggest measures. I don't have a lot of data on that specific data, but I can get it to your team. I do know that because of their age, that measure is not, often they don't get out by the time they're still compulsory school-aged or even allowed to attend school in the DOE, so they often don't have post-program attendance, meaning if they get out and they're 21, or like, it's very difficult for a student who gets out, let's say in the springtime, who had been disconnected to school, to go back to another school. They don't want to because they say, well, by 21, I'm going to be dropped out.
Young adult enhanced supervision and they go to SCURE or they go to other housing, have you tracked whether they continue to go to school while they're incarcerated?
But we can track it. I mean, it's something very easy for us to do and find out. Because it's a small number, so we could just look them up one by one.
Thank you very much. I really appreciate the work that DOE is doing now with some of the stuff, such a dramatic change from the openness cell studies.
Much better than cell study, we agree.
Terrific to have them involved. And I've watched the training, and I've seen the emphasis on the solving quadratic equations that characterizes ESH education. It's great. I hope that, are you going to be running schools during the summer?
Yes, we always have school during the summer. We always have school during the summer for all mandated 12-month special ed students, and we have to sit down with the department and figure out what we do with the 18 to 21-year-old population.
Right. I think it's very important to not, since programming is so fundamentally linked to education there, that if you can do that, one of the possible explanations for the we think that the secure program, not architecturally and not actually in terms of this, is a better approach for the department rather than the shackling of ESH. But we noticed in our review that the number of hours of education in secure is extremely low, that people are getting less than an hour a day of actual education. Perhaps, do you think that might have some relationship to their success rate in math and
yeah, it's hard to say. It's an interesting question. You mentioned the architecture because it's when they're coming. I think one session in ESH they live right there, and then the other session they're coming from different areas. And we see, it's with secure, they're right there, right next to their living area. So they could kind of, I think it's easier for them to say, oh, I'm going to go back now, because that's in my conversation with the teacher in secure, that's pretty common, where a student will come for, like you said, an hour and then say, I want to go back. And I think it's just easier because it's so close, potentially.
You don't think it's because of the separation by SRG or other separation that the department only brings someone to you for a limited period of time?
That's possible. I'd have to look at each one. The numbers, again, are so small and secure. I mean, I've observed secure 4 or 5 times this year, and every time I've observed it, it has always been a student saying, I want to go back early. That's just been my own observations. So it's hard to tell. We try the SRG status and a lot of that stuff we kind of leave to DOC. We try not to get into that too much because we have enough to worry about with math and regents and everything else. Too much to keep track of. At ESH?
No,
at Secure, we have a teacher there for 3 hours every day.
One teacher there for 3 hours.
Yep.
And so if it were the case that people were separated by groups, then they would only be able, and there were 3 different groups. I mean, they're housed in different quads at Secure. Anyway, if you could look at at how much time that people actually have, if you only have 3 hours and there are multiple different groups, it would be hard to give the 3 hours.
Absolutely.
So if you could check on that, and I guess we'll get a copy of what you presented.
Yes, I meet with the data team quarterly for the board, just with DOE data, and we provide a monthly. I think it's monthly, a monthly report or some kind of regular report.
One last thing, I'm sorry, I'm going to get it wrong. EIS, is that what's the special program that people with disabilities are supposed to have? Are you meeting that requirement? The IEP, I'm sorry, are you meeting the IEP requirements for these persons? You have the paraprofessional support or the
Under the Hanbury litigation, which is what governs how we do special education on Rikers, we take the student's IEP from the community and we develop a separate special education plan for use. It's like a temporary IEP for while they're in jail. The reason for that is when they leave jail, we don't want to amend their IEP because then it would take away the rights that they had in the community, and then the new school would have to develop a new IEP. So this is sort of an IEP that exists while they're there with us, and it's called an SEP, a special education plan.
Sort of why did you come? I have to use this opportunity to ask you just about the young adults in general, because I know when I was attending DOC's advisory meetings and GMDC was getting set up as the young adult jail, we were all, I think most of us thought GMDC and the young adult plan that Commissioner Pont had created was in general very, very successful. We know we had some difficult young people that had to be moved out of GMDC for safety reasons, but my understanding was enrollment was up. We had the PEACE program where young people were going to college and the like, and I'll be candid, I'm very concerned about the department closing GMDC, especially given the incredible work that Wynette Saunders and you and people who've been meeting together for years to create that unit. So my question is this: as they close GMDC and they start to disperse the young people about the jails, and they've already done that in creating some blended units in some jails, how is the Department of Education going to try to meet the educational needs of all these young adults as the young adult plan in GMDC is dramatically changed?
That's a great question. So we're meeting with the department to figure out sort of the numbers at each facility and what makes sense to staff. So we're already in plans to discuss, putting education into other units where we may not have been in the past. Whereas, because we know there may be one place, maybe RNDC, we're not sure yet where most of the people are going to end up. But wherever there are students, our goal is to make sure that we have the right programming where people can access it. So that's one thing, is just making sure we have the right staff in place. And two, I think we want to continue as many of the additional programs as possible with the department. So one of our biggest collaborations was about Trading Futures, which was the career and technical education programs. Those are continuing. We still have those teachers in place, and we have shared interagency budget with the department to work on that. We know we're actually excited about the possibility of a mainly 18 to 21-year-old population at East River, because it actually allows us to focus them on a different way. Most of these students are going to end up being high school equivalency students. We know that from the data, and so we could really zero in on that and enhance the career and technical and college opportunities that we can offer for that population. So we're excited. We think we've got a good plan moving forward, and really it's just a matter of figuring out how many people we need where. We've obviously been very preoccupied with the 16 and 17-year-olds as well, and absorbing them into our Passages Academy program.
On this, and I know at least when I was attending all the meetings, it was essentially the Department of Correction that was ascertaining whether the young people wanted to go to school, and I don't dispute that they used their best efforts to truly try to ascertain it. But a teacher, somebody within the educational system sitting down with a young person about their education is very different than security staff. And at least when I was very involved in this, it was the Department of Education was not going and meeting with all the young adults, but you were being informed through the Department of Correction. And my understanding is when they were leaving GMDC and going out into the blended units, it just seemed like there were a lot less young people interested in education. So is this new plan going to consider and have a part of the plan that DOE will be going out to speak with all the young people dispersed throughout the jails, at least until they move to RNDC?
We were very lucky to have a really good pilot that worked, not to convince people to come to school, but at RNDC. So we have, for the last year, have had education staff in the intake housing unit at RNDC, mainly to ascertain educational needs and goals, high school or high school equivalency. We reviewed transcripts with them. We think we can replicate that process in the jails with the 18 to 21, and that's something we're talking to the department about. So actually embedding our staff into new admission housing so that we can meet with people right there. DOC, I think, would still continue the responsibility of actually asking for, whether or not you want to go to school. I think that there's some rules around that they have to keep doing that, but we kind of want to have a double check on that and also ask them themselves. Also, Judge, since you were on the advisory committee, we also did reform our processes at GMDC, so we started to call down every single student as opposed to just students with the 3503s. And so it hasn't led to the uptick in enrollment and attendance that we want, but we've really been trying to focus on that we have blanket coverage, that we get to talk to every kid and make sure that they have an opportunity to sign up for school, as well as the Department of Correction.
Thank you.
Thank you.
Thank you.
I'd just like to make a comment. Mr. Marinacci, great presentation. But a lot of people don't understand that it's not only you good to have a good presentation, you're just an amazing individual, and what you do is incredible.
Thanks,
I mean,
Jim.
I've seen it flip from years back where teachers didn't want to be in school and they were just waiting for that, the bell to ring just to get out, to, your teachers having passion. Those numbers in ESH, it's not hard for me to figure out. We went there, we spoke to the officers, we spoke to the captains, we spoke to the DEP, who all have a passion for what they do. Even the newer officers, you could tell there's a communication they have with those young men in the ESH. And your teacher thinks of them as his kids. That Jay is just like amazing. They're my kids, and my kids are doing great, even though I'm not crazy about the seat. If we didn't have the seat, they'd be killing each other, exact words. And I'm not able to teach them inside the cell, so I'm able to teach them outside. And his passion for those kids are just amazing. So I think those numbers to me are clear from the visit that I made, based on Dep Renee, the captains, the officers, brand new officers that did an amazing job talking to the individuals and guiding them in the depths. It's, to me, I thought younger officers was not a great idea, but they showed to me that they have passion for what they do too, and it's a communication. So what I saw, and it does not make me, those numbers are definitely not surprising to me. And like I said, it's really a tribute to your guidance, your leadership, the department, the officers, the captains, everybody doing it right now, because it's making a big difference. I know if we had them locked in a cell and we had to utilize that when we were doing cell study, nothing was happening. The papers were coming back. It was a way of saying we're doing something, but getting them out and putting the right teacher in the right place is the only way it could ever happen. And thank you.
Thank you.
Thanks very much. We need to move this along. Sorry.
Good morning, Board.
Morning.
First, I'd like to say, Mr. Perino, thank you for recognizing uniformed staff in regards to ESH and also programming. A lot of our uniformed staff go unheralded and unrecognized, and they're a vital piece of a program like this, at the interrelated pieces of programming, education, mental health, and uniformed staff are vitally important. So thank you very much. So as you may know, I'm Acting Deputy Commissioner Mike Tauzik, Adult Programs and Services. I wasn't able to be here last meeting, so what I hope to do today is just present, in terms of the variance, context of several different areas for you to just have both a finer point and a broader stroke in regards to what's going on in ESH, particularly since January. So as everyone knows, there have been some modifications to the unit since its inception. In fact, in about 30 minutes, there'll be the commencement of ESH reviews for those that are coming up on their 30-day, not 45-day reviews. And that'll take approximately 2 hours to complete those that have to be seen today. So we use a week range in order to get everybody seen in a timely manner. If we have a multitude of reviews, we actually extend that out to the next day. But we make sure with the people in the room, including the chiefs and the deputy warden, that those reviews get done, that they're being seen objectively and fairly, and that they have a voice in the process, which is something new to this program here. And I'm happy to report that by them having a voice, by them being repeatedly seen, that we've had 0 incidents since this has taken place, since we introduced the inmate as part of the formal process. And what that shows to not only to the board, but to the department, to the population, but also to others involved, whether it's union members, uniform members, that this can be done constructively and safely and in a timely manner. So from a finer point of view, as you may know from the last meeting, we have reviewed over 380 inmates since we began this process. And while that may seem like a number, that is an Herculean effort on our part to get individuals down, to be seen, to review not only their programming history, but also their compliance with rules and expectations within that program, as well as getting direct feedback from them. So, and we're using that process contemplatively. If you look at the numbers, out of those 385, the bulk of our movement has been in that middle area to advance to level 3. So that is that 30-day process in which they were at a level 1, that they progressed, and now we're reviewing them out of cell. So a lot of that aggression, anger has potentially come down, and therefore they're ready to move to another level. But what's important about that, as I stress, is that everyone has a voice in that process. So we're looking at logbook entries, we're looking at disciplinary history, we're looking at program information to see how they're moving on that continuum. Maybe not necessarily of change, but at least with rule compliance, and that they're moving through the process safely. So for our young adults, my team has completed 48 reviews of young adults. So that doesn't necessarily mean 48 individual young adults, but 48 reviews overall. And out of those, from level 1 to level 2, 21% of those at level 1 have progressed. And so that means that we're looking at everything to make sure that they're moving in a safe and effective manner. And during those reviews, there has not been one instance where they said that they felt unfairly secured to a table during those reviews, and they do have a voice on that. And I'll get into a little bit about that in a second. And also, for our level 2s to level 3s, 64% of them have advanced to level 3. So once again, we are looking at everything in a very scrutinized manner. We're looking at all aspects of that individual's housing in that unit before we safely move them on. And then also, which is a notable number, is that 14% of those at level 3 have been recommended to move to general population. So what we're seeing now, within the complexities of SRGs and just institutional life as a whole, we are seeing now a flow, and now we're trying to strategize how to better manage actually the flow in the middle due to a lot of complexities involved with SRGs. So that's some of the finer points, and of course, I believe you have all the data representing all this information. But for the program information, since January, we have taken a harder and more stricter look at our challenge program, which is the anchor program in that unit, and is safely being delivered both in cell and out of cell for young adults and adults. Our counselors that are working the floor, working one-on-one and working in groups, are better detailing the progress for those that are in the program and what they've completed before moving on to another level. We've introduced the tablet program into our level 3 right now. It's soon to expand to level 1s and level 2s. And as you may know from previous conversations or hearings, that those tablets include an educational format, and that they're able to, based on rule compliance, their interaction with uniform and non-uniform staff, they're able to gain access to an entertainment component of that as well. And soon on those tablets, we're going to have programs dedicated towards reentry. We have programs dedicated to just thinking differently while incarcerated, and how what you think and how you perform in an institution directly results in your success in the community. So some of our programming is even being built to ensure, or at least offer them an opportunity to be successful once they reach the community. We also have a podcast program, which is one of the first programs in the country delivered this way, in which we have anti-gang messaging that they're going to be able to feel confident and safe enough to listen to in their cell, and hopefully to get them to start thinking differently about their criminal lifestyles while they're incarcerated, and they don't feel that peer pressure while they're in group to listen to these types of messages, that they can listen to them independently in their cell and then start the process, hopefully, to step away from that type of lifestyle. The third piece that I just want to touch upon real quickly has to do with institutional stressors. There's not a lot of research out there on what leads to prison violence and prisoner discipline, problems with discipline matters. But we know that there's a few key predictors there. One of them is consistent administration and consistent staffing. So if I can stop there for a second, with the help of Chief Mingo and our warden staff and Dep Renee and his staff, we have steady presence and steady management in that unit. And it's starting to pay off under the current model. Our detainees, our inmates are going to staff. They're talking to staff about various conflict issues. We have that period of time for them to develop the rapport and develop that communication stream with us to open up more, particularly in a one-on-one or one-on-group fashion, in a multidisciplinary team experience, to offer us information that they may not share. It gives us time to develop and cultivate that relationship with them, as we talked about before. The other issue that comes up is a gradual reduction in idleness. We're introducing more programming. By having the 30-day period, or with the variants, we're able to look at them over a period of time and see what programming they're doing and see if we can look at those cues to see if some of the information is being absorbed. The other item that leads to problems is rapport. So as I just spoke about, we not only have a consistent administrative and management team in this program now, we have a presence in this area as well. By senior leadership, chiefs coming in on weekends, conducting tours, meeting with inmates, talking to staff, deputy wardens, deputy commissioners, other headquarters staff that are immersing themselves into this unit to figure out how we could do things better, because nothing is static here. We have to be very dynamic with how we manage a very sensitive population to make sure that everyone is safe and that we can be successful with this program. So I leave it at that. It's a pleasure to meet you as well.
Made under enhanced supervision. I just do have two questions. One, it sounds like there's been some change in staff that maybe I wasn't aware of. And so I just want to clarify, you had said, I think you're in charge of adult programming. I know in the past, the young adults, when Commissioner Pond had the young adult plan, the young adult programming as well as the adolescents was under Wynette Saunders. Now you're in charge of adult program. Does that mean that there's been a philosophical shift in how you look at the unique needs of the young adults? Because we know nationally and internationally, young adults are, because of their unique needs, you know, the neuroscience, the brain's not fully developed to 25 and the like, tends to be treated more similar to an adolescent than an adult. So I was just curious as
I'll
to
let
this
DC Saunders talk about the historical piece of that, but just so you know that we're lockstep in terms of our philosophical approach to risk reduction, so I'll let her speak and then I'll come back.
And then I'll have one question after that. Yes.
So good morning, everybody.
Good morning.
My colleague DC Tosek and I share the same philosophy. As you know, his presentation was mostly focused on the blended units today because we have young adults in those units. However, as you know, in 3 South is where all the young adults is where young adults are as well. And what we've done is we've developed a programming plan that includes cognitive behavior modification and the principles, as well as, as well as information on de-escalation and different things of that nature. So, for example, as you know, the board and the department has been working on what are the elements that we need to ensure that are included in ESH regardless of the population. So we've been sharing many of those principles so that they are duplicative of what's needed for both populations. So, for example, safe crisis management, the cognitive behavior modification, the interactive journaling, all of those things, evidence-based programming is available in both blended and the exclusive unit.
If I can speak to the age thing real quickly in terms of age ranges, if one of the programs that I cited that we're going to be implementing is this podcast program, which is think of it as a 3-tiered anti-gang messages, which starts at first of why individuals actually enter the lifestyle, then all the way to reverse engineering one's life for goal setting and the things of the such. So that message, that particular podcast that would be delivered, may be delivered from an adult, but it's also going to be delivered from a perspective of being young and why that individual actually entered into a gang lifestyle. So just so you know that.
Yes, yes. So, you know what we hear from some of the advocates is this, that there are young people who might not want to be in restraint. And we all know that the programming is really, really important, right, to their
Correct.
Progressing as well as to their futures. But there are supposedly young people, and I can appreciate it, not wanting to be restrained for hours, and so therefore they choose not to come out and be restrained, and therefore they don't get the benefit of the programming. And I understand their failure to comply with the programming is a basis a factor that's considered as to whether they can progress or not. So is there a reason, or how do you sort of accommodate a young person who really just can't bear to physically be restrained for that long a period of time? Because I'll be honest, I could not be restrained that long.
So if I can be Michael Blaine for a second here and give up some of the secrets behind the curtain. These are pretrial detainees, so they're not sentenced, so therefore we don't have good time and case plan adherence to utilize in terms of trying to offer programming and stimulate change based on a required program. What we look at is the rule compliance in order to advance somebody through a system. The programming is helpful in allowing us to gain insight in where that person possibly is on that continuum of change. But we've had individuals that were just not ready for programming. They may be doing their own something individually in their cell through a prescriptive, targeted fashion that maybe they'll gain more from journaling. So that information is also included in that analysis. But at the end of the day, this is about safety and security as well as trying to move someone through through the program on their own. So we have to look, and the main focus is on rule compliance and those patterns of behavior that lead to violence.
Against them if they won't come out to be restrained to
No.
sit in the program? That
Not at
won't
all.
be held
No.
against them during the
No.
review? Okay.
So just real
That was my
quickly on
misunderstanding.
patterns of change within corrections, a lot of the focus on restricted housing areas focuses on individuals that are in cells for hours at a time, the old 23-1 model. What this program allows is for them to be out for an extended period of time with the choice to take a break for mobility purposes, to go in to use the bathroom. There's showers that are going on during this period of time. There's visits that are going on in this period of time. Or they may come out for a while, engage with a counselor one-on-one or in a group, and then decide to go back. And some of those individuals continue their work in cell. So this model is actually moving drastically away from the traditional model of 23-1 to 7 hours out, and how can we do that safely? And I think that's what we should all be proud of, is that these individuals are building rapport, engaging safely with staff, and at times, their peers out of cell, and not talking through a vent, not talking side door, not being alone in a cell, but actually out.
Thank you very much. I learned a lot from your presentation. When we looked at the March data, all the people who were in ESH level 2, there were 5 of them. They had their 30-day reviews. 4 of them were recommended to go to level 3, but they didn't go because there was no housing capacity. That's not quite, and so they didn't get access to what you described in level 3. When we looked at the 10 people who were in level 1, one of them went away. So 9 of them continued. 9 of 10 continued at level 1, except for one who wanted to stay there. So the 20% that you're describing, is that for blended young? Is that for all?
I gave you blended young adults.
Because we're talking about YESH, and you're providing us with data that's not about. Could you give us that data?
I gave you
young adult data only.
Specific young adult. I can have DC Saunders.
Well, that's what we need, because that's what we're voting on.
DC Tosek did give you the combined numbers.
Yeah, but he's asking for the young adult.
Give us the young adult data.
No, that was it.
That's only young adults. So you're
Yes.
saying 20% overall have gone from.
Yes, I stand corrected. I'm sorry if I confused you. On
okay.
That.
And that's been in last. What was it like in April? What percentage of people left in April? Do you know? And in March we don't have. We have just 1 out of 10.
Our data was as of up to April 9th.
Cumulative?
Yes.
Yeah, oh, okay. And do you think use of force has decreased in ESH? I mean, our data shows that on the average of the 5 months since November of 2017, when there were four uses of force, when the cumulative rate of use of force was about 4, it was on average 9 the preceding 5 months. It appears to be going up substantially.
I'll defer to uniform staff for that question.
Okay.
Okay,
Sir?
we can move to the variance now.
Pardon?
I'd like to move
Okay,
to
that's
the
fine.
variance
Okay.
discussion.
So if I
of the-
can have
Yeah, that's
Deputy Warden
fine, but
Renee
we-
come up, please.
No, we're going to. Okay. That's fine. I agree with you.
Yeah. Yeah, yeah, yeah.
Doing the variance? Are we moving on to the variance?
That's what we'd like to do.
Okay, we're ready.
You've already presented it, right? You've
Correct,
already- so
correct. I'm waiting
that
for,
part's done, so
waiting
we'll
for
go to our
your,
part.
yes, your part, yes.
They've already asked officially for the variance.
So where are we now?
Chief Mingo did that.
Which
So that's-
variance are we dealing with? The
ESH.
secure? Oh.
So let's make a motion.
Yes, so I need a motion to have a vote on the variance. Is there a motion? Is there a second? Second. Thank you. Do we need to read the conditions first, or do we need to?
Yeah, we should open the floor for debate and conditions.
Yeah, we open the floor for debate and conditions. I believe the board is prepared to vote on the existing conditions as a group.
So we'll start with the existing conditions on the variance, which I will read. They were last approved by the board as part of the November 2017 variance. So I will read those existing conditions now, which the board will vote on to additionally attach to this request. The department may operate multiple levels of young adult ESH, with level 1 being the most restrictive. There shall not be a separate unit for assessment purposes. 2, each request for approval of a placement of a young adult in young adult ESH, i.e. any ESH unit where young adults are housed, must be in writing and specify the reasons why a less restrictive housing setting is not a safe option. If the placement is to include the use of a restraint desk, the request for approval must include why young adult ESH without restraint desks is not a safe option. The chief of department or designee must also specify her reasons for approving or disapproving the request for young adult ESH placement. If the placement is to include the use of a restraint desk, the chief or her designee must separately approve or disapprove this use and specify her reasons for approving or disapproving the use of a restraint desk. The request for approval and the chief's or designee's approval or disapproval thereof shall be sent within 24 hours to the person who is the subject of the request, New York City Health and Hospitals, and the board. 3, the department shall not keep canines stationed in young adult ESH units. 4, the department shall provide all young adults housed in ESH with a minimum out-of-cell time of 7 hours per day, not inclusive of school hours. If exceptional circumstances occur where the department cannot comply, it will notify the board immediately as to the reasons why it cannot comply. 5, the department shall notify the board in writing every time the lockout periods in young adult ESH do not start on time and the reasons therefore. The department shall provide written notice to the board within 24 hours of such occurrence. 6, the department shall conduct and report on a monthly audit of its compliance with BOC minimum standards 1-05B lock-in, specifically the number of out-of-cell hours per person, 1-08F, access to courts and legal services, including law library, 1-06, recreation, and 1-02, C2, classification, specifically the number of programming hours offered to each young adult and the number of hours each young adult participated in programming. The department shall provide its monthly audit to the board by the 10th business day of the following month. 7, where the department is permitted to consider a young adult's activity occurring or actions committed at a time prior to the instant incident in connection with the young adult's placement in young adult ESH. Such activity or actions must have occurred within the preceding year. 8, the department shall offer 5 hours of programming to each young adult in young adult ESH each day. For young adults enrolled in school, the 5 hours of programming can include 3 hours of school. 9, the department shall provide the board with a public report on the implementation of the foregoing conditions. The requirements for this report are outlined in a document titled ESH and Secure Unit Variances, Public Reporting Condition, dated May 8th, 2018, and is available on our website. 10, on at least a monthly basis, the department shall provide the board access to all documentation considered in young adult ESH placement and review decisions for young adults. This includes, but is not limited to, all records reviewed or created by young adult ESH adjudication, health and hospitals placement review, the chief's reviews, the young adult ESH entry unit review committee, and the young adult ESH 45-day periodic review. On a monthly basis, the department shall transmit to the board a list of all young adult ESH placements and reviews. The department shall provide this documentation for each month by the 10th business day of the following month. Documentation for the month this variance expires shall be provided by the 5th day of the following month. 11, by September 11th, 2018, the department shall submit an update to its June 2017 evaluation of enhanced supervision housing for young adults. The update shall focus on outcomes and include progress updates on the issues they and the board identified in the initial report. Excellent timing.
So these are the existing conditions. Would a board member like to propose renewing these conditions? Is there a second? Second. Any debate about these conditions? Remember, these are existing conditions. Okay. Department, do you want to comment on the proposed conditions? No.
We are fine with the existing conditions.
So we now need to vote on the existing conditions. We'll have a roll call vote. Mr. Reagan?
Before I vote, I just want to say I think that this issue is about safety. I think this issue is complicated. I don't think any of us, I've been to Rikers Island, I've seen the desks. I know, that they're tough stuff. And but at the same time, we need to have a safe environment. We need to have people feel comfortable. We need to have real teachers be able to teach. We need to be able to do things in an environment that's safe. I vote yes.
Thank you. Dr. Saffron?
Yes.
Yeah.
Yes.
Reno?
Yes.
Yes, as to the conditions.
Yes, as the conditions. I'll comment when we vote on the actual variance, but I vote yes for all the conditions.
Yes. Same here. Vote carries. So there were unanimous, all, yes, 8 of us. Now we're going to have, Martha is going to discuss and explain the proposed new conditions.
There's 4 new conditions to be added and discussed and voted upon by the board here. This first condition actually was a part of the variance some iteration ago. We're returning it back to this variance. This condition reads, a young adult can be placed in young adult ESH level 1 only if the person has recently participated in an actual or attempted slashing or stabbing or engaged in activity that caused serious injury to an officer, another person in custody, or any other person, and provided that the use of a restraint desk is the least restrictive option necessary for the safety of others. The next new condition to be added would be restraints, including restraint desks, shall not be used except to control an incarcerated person who presents an immediate risk of self-injury or injury to others, to prevent serious property damage for healthcare purposes, or when necessary as a security precaution during transfer or transport. When restraints are necessary, the department shall use the least restrictive forms of restraints that are appropriate and should use them only as long as the need exists. The third added new condition. The department shall review each young adult in ESH Level 1 every 15 days to determine whether the person will advance to a less restrictive level or unit. At each such review, a young adult will advance to a less restrictive level or unit unless 1, he has engaged in violent or aggressive behavior while in his current level, and or 2, there is credible intelligence that he may engage in additional violence in a less restrictive unit, and or 3, he has willfully disregarded rules and regulations, and these instances are reported and documented. If 1, 2, or 3 is applicable, DOC shall make a specific determination that the restraint desk remains necessary to control this incarcerated person who presents an immediate risk of self-injury or injury to others, or to prevent serious property damage. The department shall commence 15-day evaluations on June 11th, 2018. The last new condition is, within 60 days, the department shall develop a curriculum and plan to provide specialized trainings, including crisis intervention and conflict resolution training to all young adult ESH staff. The department shall update the board at the July public meeting as to its projected timeline for implementation.
Thank you very much, Martha. Could I have someone please move to vote on these new conditions? Is there a second? Thank you. Any questions or comments or discussion on these new conditions?
I would like to hear the department's response to these conditions.
We accept the 4 new conditions as read.
Thank you. Anything at the board? No? Thank you. All right, we'll take a roll call on this. Mr. Reagan?
Yes.
Dr. Steffer?
Yes.
Mr. Perino?
Yes.
Judge Hamel?
Yes.
Yes.
Dr. Cohen? Mr. Jones-Austin?
Yes.
Thank you. I'm in favor of it. Thank you very much. Motion carries. The new conditions are now part of the overall variance. Thank you. The next item is the secure unit variance. Oh, I thought you just did, no? Oh, okay. So now we vote on the variance itself with the new conditions, correct?
And
Okay.
all of the conditions that were just approved.
All of the conditions, the original variance, the original set of conditions, and now the new conditions. Mr. Reagan?
Yes.
Dr. Sapir?
Excuse me, I think we have to move the item
We have
and
to
have
move-
it seconded and then
Okay.
open for discussion.
the
I
item.
only have very brief comments.
That's fine, okay.
Move the item.
Second? Yep, Judge Hamel.
Yes, thank you. This will be very quickly. You know, we've been approving this variance for 2 years, and I really, really appreciate the effort on behalf of all of my colleagues, the Board of Correction staff, and the Department of Correction to try to curtail the use of harsh treatment, 7-hour leg restraints in this unit. And I can see that the Department of Correction has made some really substantial progress, and I commend you on that, reducing the review time. You went from 45 to 30 days on your own. Now you've gone from 30 to 15 days at our request, letting the young adults participate. There's a multidisciplinary approach. There's much more programming in place. Education is going well and the like. However, I still do agree with the City Council member, Danny Drum, and the young man that spoke, that this is less than therapeutic when it repeats the deleterious effect of punitive segregation, which is isolation, and then has the alternative of the leg restraints. As we continue the rulemaking, I understand the Board of Correction will continue to work with the Department of Correction to continue to try to curtail the use of restraints, work out alternatives, and work to create a more humane therapeutic rehabilitative unit for those most in need. In my opinion, the review should be much more frequently than every 15 days, since we're really applying the ABA standards, and that's that they shouldn't be restrained unless they're really at imminent risk of hurting somebody or themselves. So the leg restraints, in my opinion, for a predetermined period, that being for 15 days, doesn't comply with the condition of limiting harmful effects. I find it degrading, harmful, and counterproductive, and therefore I will vote against the variance, but I do recognize the substantial progress that is being made.
Dr. Cohen?
Yes, I concur with Judge Hamel's comments. I do give credit to all for the very intensive oversight of this what I think of as a punitive and cruel unit that is ESH. I'm glad that we've added conditions to our monitoring, and I'm glad that you're putting all the time into it because it's totally appropriate to worry a lot when the department is shackling people. The board never, the board, when we made rules limiting solitary confinement several years ago, did not envision actually prohibited the use of ESH for young adults, and we had no idea that the department intended at that point to create more in addition to the very positive things that have been done, some situations which are much more punitive, particularly the use of leg restraints, tasers, attack dogs, which have now been removed from this unit but previously were required. So this has been a too long a journey, and I hope that before or by the time that we next evaluate this, we will no longer be routinely restraining young adults the way we are right now. When the department agreed to when the department agreed, and the board required the ending of adolescent solitary confinement, it was a complex process. It did not go smoothly. There were lots of problems. The first part of it getting, right at that point, 25% of the adolescents were in solitary confinement. And it was not easy to change from that, but through leadership from the department, leadership that's on our board right now, former Warden Perino, the department was able to reach the point of today where 16 and 17-year-olds are not in solitary confinement. And that's the goal that we have to, and I think similarly with restraints, we really have to do much better than that right now. I think that the secure unit, which the board approved, that we worked with closely with the Department of Correction to develop a systematic approach to dealing with these young men who had committed very dangerous acts, was the right approach, and I urge the department to consider an expansion of secure, which takes into account the programs that have been effective in ESH, but has small units with adequate staff. If it's 1-to-1, if it's 1-to-2, that does not require the humiliation and the cruelty of the restraints which now characterize ESH1. So I'm going to be voting against this motion, and I'm hopeful that soon the department and the board will collectively end this embarrassing practice for the city of New York. Thank you.
I think that a good number of us on the board, probably a majority of us on the board, do hope that the department and the board can come to some kind of a resolution and move away from the use of restraint desks, subject, of course, to any legitimate safety concerns. So I think we all feel that this is something that we need to approach shortly in the next coming months to try to find a way to move away from that. Anybody else on the board care to comment at this time before we take the vote? Okay, the final vote on ESH and young adults. This is a vote to adopt the new variants with the new sets of conditions. Extend the variance with a new set of conditions. Mr. Reagan?
Yes.
Dr. Steppier? Yes. Mr. Perino?
Yes.
Judge Hamill?
No.
Dr. Cohen?
No.
Ms. Jones-Austin?
Yes.
And I vote yes as well, so it carries. Thank you very much. So it's 5 votes in favor. The next matter is a consideration of the second variance, which has to do with the secure unit variance. In May of 2016, the board first granted variances from minimum standards 1-05B and 1-08F to allow the department to provide young adults in a secure unit with a minimum lockout time of 10 hours and access to law library services by means of a law library kiosk and a typewriter. The board last renewed these variances on November 14, 2017, to expire on May 22, 2018. The department has now asked the board to consider a 6-month renewal of the variance allowing for the operation of Secure. They have additionally requested the board consider amending the minimum standards to incorporate this variance permanently. We will vote today on the variance request and review the permanent incorporation in our ongoing restrictive housing rulemaking process. Will the department please present this variance request?
Good morning again. The New York City Department of Correction is requesting a 6-month limited variance renewal to the Board of Correction minimum standards 1-05B lock-in and 1-08F access to courts and legal services for the purpose of maintaining the use and secure unit.
Thank you. The board will have an opportunity to discuss this variance request and any proposed conditions prior to a vote. Now, I'd like to ask a board member, will the board member move to vote on the requested variance of the Department of Corrections 6-month extension commencing on May 23rd, 2018, during which the department may provide young adults housed in secure units with a minimum lockout time of 10 hours per day and access to law library services? Does the board member want to move this?
So moved.
Is there a second?
Second.
So I'd now like to open the floor up to debate and discussion among the board members. Anyone who has anything they'd like to offer at this time, please do so.
I just want to say that I do fully support this variance. I think that this has generally been shown to be a pretty successful model. I was a little disappointed to hear the educational data from Nick Marinacci, and I hope that we can improve the young people going to school there. But in general, I think it's a good model, and I support it.
Dr. Cohen?
Yeah, I also support this variance request and urge the department to expand the secure unit with a much more informed architectural sensibility than was created first with the board's cooperation. We can do better than that. I think it's important to have a unit like Secure, which provides a safe. Provide safety for the entire institution by isolating persons who have recently committed dangerous acts, and I'm going to vote in favor of this variance.
Yeah, I would also like to support secure unit. It's been running well. The staff there, the captains, the DEPs all have communication with the individuals. They actually, don't even utilize or haven't utilized to a very minimal extent the decks, actually, because they're able to control a smaller population with a very intense, well-trained staff there, including supervisors and the correction officers. So I think that's a really great direction that the department's going in, and they should continue, and I definitely support it.
Martha?
Okay, so I believe the board is prepared to vote on all of the existing conditions on the secure variance as there's DOC and BOC agreement on these. They were last approved by the board as part of the November 2017 variance approval. I'll just read them on the record now. 1, restraints including restraint desks shall not be used except to control an incarcerated person who presents an immediate risk of self-injury or injury to others, to prevent serious property damage, for healthcare purposes, or when necessary as a security precaution during transfer or transport. When restraints are necessary, the department shall use the least restrictive forms of restraints that are appropriate and should use them only as long as the need exists, not for a predetermined period of time. 2, the department shall not use restraint desks in secure units except in the secure unit school area and only when A, extenuating safety or security circumstances or specific credible intelligence of a safety or security threat require their use, and B, the deputy warden of Secure approves their use in writing. The department shall provide written notice to the board on a weekly basis stating whether restraint desks were used and specifying the circumstances that required their use. 3, The department will make every effort to A, increase the number of staff present and supervising young adults during secure unit school sessions, and B, keep the number of students to a safely manageable number without restraint desks by adding multiple school sessions if necessary. 4, the department shall not use 3 or more point restraints in secure units. 5, the department shall A, provide all young adults housed in secure units with a minimum out-of-cell time of 10 hours per day, except for instances of de-escalation as set forth in the department's written directive concerning secure units. B, provide all young adults with due process in connection with their placement in secure. And C, exclude all young adults with serious mental or serious physical disabilities or conditions from placement in secure. 6, the department shall notify the board in writing every time the lockout period in secure does not start at 5 a.m. and the reasons therefor. The department shall provide written notice to the board within 24 hours of such occurrence. 7, during the pendency of this variance, if the young adult in a secure unit has not committed an infraction within the preceding 28 days, the young adult will advance to a less restrictive level or unit, unless 1, he has engaged in disruptive, violent, or aggressive behavior while in secure unit level 1, and or 2, there is credible intelligence that he may engage in additional violence in a less restrictive unit. 8, where the department is permitted to consider a young adult's activity occurring or actions committed prior to the instant incident, such activity or actions must have occurred within the preceding year. 9, the department shall conduct and report on a monthly audit of its compliance with BOC minimum standards 1-05B, lock-in, specifically the number of out-of-cell hours per person, 1-08F, access to courts and legal services, including law library, 1-06, recreation, and 1-02C2, classification, specifically the number of programming hours offered to each young adult and the number of hours each young adult participated in programming. 10, the department shall provide the board with a public report on the implementation of the foregoing conditions. The requirements for this report are outlined in a document titled ESH and Secure Unit Variances, Public Reporting Condition, dated May 8th, 2018, and available on the Board of Correction website. 11, on at least a monthly basis, the department shall provide the board access to all documentation considered in each secure placement and review decision. This includes, but is not limited to, all records reviewed or created by Secure Unit Adjudication, Health and Hospitals Placement Review, the Chief's Reviews, and the Secure Unit Support Team. On a monthly basis, the department shall transmit to the board a list of all secure placements and reviews. The department shall provide this documentation for each month by the 10th business day of the following month, except documentation for the month this variance expires shall be provided by the 5th business day of the following month. The end.
Thank you very much, Martha. What Martha just read were the existing conditions to this variance. So I want to ask the department if they care to comment on those.
We agree with the conditions and thank the board for their support. Appreciate it.
Thanks very much. From the board level, any comment or questions about these conditions? So now we'll do a roll call vote with respect to these conditions. Mr. Reagan?
Yes.
Dr. Sapir?
Yes.
Perino?
Yes.
Judge Hamel?
Yes.
Dr. Cohen?
Yes.
Ms. Jones-Austin?
Yes.
I vote yes. So we have unanimous vote on that. Are there any additional conditions or new conditions that anyone wants to propose? Hearing none, we will now have a vote on the variance extension as we all just heard. Mr. Reagan?
Yes.
Dr. Stafford?
Yes.
Perino?
Yes.
Judge Hamel?
Yes.
Dr. Cohen?
Yes.
Ms. Jones-Austin?
Yes.
Thank you. I vote yes unanimously, and it's carried. Now we will come to the general public comment. Again, we all know the rules. You will have 3 minutes per speaker. In addition, or instead of your oral testimony, we're happy to receive any kind of written comments. You can leave your comments on the table outside. The first speaker is Kelsey D'Avila.
All right, hello again. My name is Kelsey D'Avila. I'm the Jail Services Social Worker at Brooklyn Defender Services. And today I'd just like to raise two concerns that we've considered before. First, we appreciate the board's ongoing focus on restrictive housing units operated by the department. In advance of the upcoming rulemaking, we urge you to investigate the use of West facility as a form of extreme punishment. Just recently, we've reported to you all about one of our clients who have been confined in West facility as a form of punishment without due process. In this most recent case, after completing a segregation sentence, our client was placed in an isolated cell for 23 hours a day with no meaningful contact or access to medical and mental health treatment. The board previously found the department's use of West facility in this way violates the minimum standards, and we urge you to hold the department accountable for this practice and request that the board prohibit the use of West facility as a form of extreme punishment during the upcoming rulemaking. Second, BDS encourages the board to add visits as an essential and standing agenda item in these meetings. Visits, support, whether that be in person or video, have a clear, documented positive effects on people and their incarcerated loved ones. As this board has heard from many directly impacted families and loved ones, visits are essential to a person's return to society, yet the department continuously threatens to limit visiting. Commissioner Brand has publicly stated the department's interest in restricting visits, and when advocates asked at a recent visit working group meeting for clarification of the commissioner's comments, the department responded that the goal is to, and I quote, to be flexible with the board's minimum standards. The department's vagueness is disturbing, and the idea that human connection is a privilege threatens the safety and well-being of people in the department's care. We urge the board to press the department for clarity and transparency. And finally, we applaud the Visit shuttle bus that recently launched and is being facilitated by the department, and encourage the department to promote transparency and open communication about the bus. To that end, we hope that people housed at Rikers have been provided notice about the existence of the bus. We also encourage the department to consider recommendations about advertising the bus, including eliminating the stigmatizing labeling in large bold letters that identifies the shuttle. We urge the department to collaborate with family members and people in custody to receive honest input. We are committed to collaborating with the department and to ensure that this initiative is a success. Thank you.
Thank you. I agree with you.
Thanks very much. The next speaker is Laura Fettig.
Hi, good morning. My name is Laura Fettig, and I'm a member of the Jails Action Coalition and a social work intern at the Urban Justice Center. You heard from me at the last meeting about visiting, and I'd like to quickly raise some concerns about the new Visit Bus program that was rolled out a couple of weeks ago that Kelsey was just talking about. First, I want to reiterate the importance of improving accessibility for people who visit their loved ones at Rikers, but it's important that a program to increase accessibility actually meet the needs of family members visiting. Jack has heard over and over from family members that visiting Rikers makes them feel like they themselves are incarcerated and that the visit process is dehumanizing and difficult. Having visitors board buses that are clearly labeled Rikers, manned by the same correction officers who have made the process so intolerable and demeaning for many visitors is not necessarily a meaningful step in the right direction. We worry that even more exposure to correction officers will subject visitors to even more abuses. A Jack member recently went to try to catch the bus from the J Street Metrotech stop in Brooklyn, and the bus was 45 minutes late. She never found a sign marking exactly where the bus stop was. There are 6 exits from the J Street Metrotech subway stop, and it was never clear which one she should wait near. For visitors who are elderly, who have disabilities, finding and waiting for the bus would be extremely difficult. This Jack member finally gave up on the bus, and as she was walking away, she saw the bus arriving, and there was no one waiting for it and no one boarded. So while I understand the idea is to add more buses if the program is a success, the schedule as it currently stands, I think will actually dissuade people from using it. What happens if visitors wait for the bus only to have it fill up before they can board? They will have to wait up to 2 hours for the next bus, and without a bus shelter, a place to sit, or they will have to make their way, as they normally would, to the Q100, adding a bunch of wait time to their visit. If DOC truly wants this to be a successful program, I would suggest that they increase buses to every 10 to 20 minutes, use MTA or other buses, staff them with people other than correction officers, add signage, a bus shelter, and I just want to read from the recent press release. Commissioner Brand said that the department's that regular contact with families and loved ones helps foster confidence and a sense of purpose. These visits help maintain a family nucleus and provide hope, showing those in custody that they are not alone. The easier it is to get to Rikers for loved ones, the more often they will visit. We believe people are less likely to return to our custody when family bonds and community connections are nurtured. And I just want to say that the department needs to take these words seriously. I appreciate these words, but if they want to make a meaningful program for those visiting Rikers, they need to rethink this program. Thank you.
Thank you very much. The next speaker is Al Craig.
Sorry,
Oh.
can I just clarify just one thing? That
Yeah, sure, go ahead.
Sorry, no correction officers are actually driving the buses.
I'm sorry?
No correction officers are driving the buses. They're actually civilian drivers driving the buses. Because I think it's been said twice, so I just wanted to clarify.
Yep, thank you. Mr. Craig?
Jeff, look into the scheduling issue.
Yeah, I mean, one thing just up front, we did this as a pilot, so we're trying to figure out, we looked at the data, so certainly in terms of getting buses and so forth, we're taking a look at it, and we're just going to try and figure out long-term what it could be.
Thank you.
Thank you.
Mr. Craig?
A couple of months ago, Elias Usamadeen and myself came here. He was called a name by Mr. Satfield. You know, to the date, we haven't received any kind of apology or anything about that. Even as a man, I think that was pretty much the thing to do. But
discussed that enough. I think we should move on from that.
I mean, sir, this is my 3 minutes,
Yeah,
right?
I know. But
That's what I'm saying. So allow me to use them as I see fit. In my lifetime, you know, I voted Democrat down the line, right? Until this year, I voted for a Republican, right? Because we have the worst mayor in the history of my lifetime for Black and Latino people. We have somebody who would spend $17 billion or thereabout for new jails while people in housing are suffering, while 60,000 people, 60,000 are homeless, 20,000 children. So we're gonna make sure that these jails are full all the time, because crime is not a Black or Latino issue. It's an act of desperation driven by poverty. And this man refuses to address this. So why am I saying it here? Right? The appointment of some of you here has to be a conflict here with the worst mayor of my lifetime. This guy appoints people who don't address issues of Black and Latinos. And the violence in Rikers Island only is happening because it further pushes this agenda of closing Rikers Island. It was a housing development in Brooklyn that was on Prospect Place that had 3 buildings. 3. They allowed crime to run rampant in these buildings. 3, which a cop outside of each building could have curtailed the crime. When the crime overwhelmed the tenants, they told them we had to shut this development down so that we could get rid of this kind of violence. It wasn't conducive to a positive lifestyle. That's what's happening on Rikers Island. You guys refuse, these people here refuse to address this violence because it's Black and Hispanic people. You refuse to do it so that these rich people can take Rikers Island. We could care less about it. But you gotta understand, if you, as a union, if you were getting rid of Rikers Island the right way by investing in summer youth, in Brownsville, Brooklyn, 2 weeks ago, 5 shootings happened. 5 shootings. So those people are gonna wind up on Rikers Island. And once again, this worst mayor of my lifetime is going to do what he said about housing. Excuse me, I'm gonna go a little long. What he said about NYCHA. He said they can get what we can afford to give them. That spoke totally different from the guy who was running for mayor. A guy who would invest that much money for young Blacks and Hispanics to wind up in a place where they could find redemption opposed to doing something to prevent them from being there. 100% summer youth jobs would stop them from killing each other. But no, they can get what he can afford to give them. See, Get right with yourself. Don't walk in here and keep talking about how you really care about blacks and Latinos. You don't. They're living in squalor in NYCHA. They're living in $2 billion for homeless shelters instead of permanent living. And then we put them in the jail, and now we got a cure for them. Oh, we got a cure for them. Everybody's talking about a cure. You ever heard this saying, an ounce of prevention is worth a pound of cure? And you don't want to do it. The reason why the recidivism rate is so high in Rikers Island is because their conditions is worse than Rikers Island. But you people don't want to hear it because it's all about what you feel good with the worst goddamn mayor of my lifetime. And you sit here and you don't do anything. I understand that you agonize over chaining somebody to a freaking death. I agonize over that too. But I have a duty. We have a duty as a union, and we have a duty as a human race to protect them from getting harmed. And so I'm going to end this real quick. I know some of you deal with housing, and let me tell you something. What these people are suffering from in these housing development, like the mayor said, they will live, or we can do what we can afford to give them. He says that with education. He says that with summer youth. He says that with everything except for jail. You got to ask yourself, why investing so much in jails instead of preventing people from coming? Now, if you in Rikers Island that way, then that makes sense. Otherwise, those 20,000 kids that are homeless, you're going to keep them in whatever new jail, old jail, half-ass jail. They're always going to keep coming. So if you really want to do something, you need to stop this violence. You need to get in his ass and tell him why is it that you're willing to invest all this money in jail instead of a better way for people to live. Thank you very much.
Thank you, Mr. Craig. Next speaker is Grace Price.
Good morning. My name is Kelly Grace Price, and I'm with the Jails Action Coalition. I just want to make my comments brief this morning. I read the directive that was issued earlier this month by the department. I believe it went into place on the 17th. And there are a few items in that directive that seem to be in direct contradiction with the PREA rule that was voted in. And I just want to focus my attention on one specific aspect of that is very unsettling to me. There is a process now, maybe my understanding is incorrect, please correct me if I'm wrong, that when a detainee makes a complaint about sexual assault or rape or harassment by another detainee, that the primary person that will investigate that complaint will be the captain, the adjudicative captain, I think is the title, to determine if that relationship between the detainees is a consensual one or not. And that particular complaint's investigative arc ends right there with that adjudicative captain. It does not go to outside investigators. And I have a real problem with this because we already know that evil exists in the dark. I've been saying this forever about Cy-Vance, but look, our Attorney General all of a sudden, there's absolutely no way that you'll be able to prevent abuse. You're actually setting up like a pimp stable within the cell blocks. If the captain gets to decide if a relationship is sexually consensual or not, there's a lot of problems here. I understand the reasoning for it because I know that there are a lot of PREA complaints that are made out of bitterness. I know a lot of people coming in and out of jails, and they tell me that PREA complaints are being made falsely sometimes when one lover is spurned and a new lover is taken on, and I understand that. But this is an issue. There needs to be a mechanism and a workflow to loft those complaints above the box that already conscripts these people into silence. I'm very worried about this. And speaking about silence, Commissioner Braun, the last time that you spoke about PREA was in September, and specifically you said sometimes we get it right and sometimes we get it wrong, or it could have been the other way around. But that's the last word that we've heard from you on PREA. Pretty please, at every meeting, could you please give us an update regarding how many investigations have been completed and what year that they track to? That's a huge behemoth black hole for everyone working to prevent rape and sexual assault. And I would like to urge the board and the department to make a place in this meeting just every month to update us on that one issue. Again, thank you for listening to me and allowing me to speak. I'm Kelly Grace Price with the Jails Action Coalition.
Thank you. The last speaker is John Coleman.
Good morning. Again, good morning. I'm thankful to be here on behalf of Just Leadership USA and the civilians. Myself, I have the distinction, good and bad, of once being out of Rikers Island. So I've seen the good, I've seen the bad of it. A couple months ago, I was working with one of the organizations that come into the called Lead by Examples, and the primary focus was to redirect the inmates there with programming. While being there, I had the opportunity to see how the structure is set up. And I can say that it is akin to like throwing wood on a fire, because with all the violence that's going on there, I see no comprehensive anger management program, because everyone's there is dealing with some form of anger management because of the circumstances, and the circumstances lead to violence. So I had suggested that they implement something like that. I worked I was an inmate in Green Correctional Facility. For 2,000 hours, I was an anger management counselor, and we had great success in redirecting the inmates. So what I'm saying to this panel here, if you want to bring about change, make that a part of your curriculum in education. Make it mandatory, you know what I'm saying, because that's going to bring about change. You can't change a person's condition unless you change the way they think, and that's on both sides. Violence only going to beget violence. The inmates in there is not going to listen to the officers because they see them as an enemy, and aggression is not going to change it. You have to do more education. I heard that y'all said y'all want to implement, y'all want to implement, I'm trying to miss a word, but y'all basically said y'all want to deal with addressing the problem with corrective. I'm forgetting it, but the main point is your conditions. You need to implement some form of comprehensive anger management program. If you would like, I have a bunch of suggestions. I would love to do it. Also, as being a part of Just Leadership, I definitely believe in the directive and the idea of Rikers Island does need to be closed. To me, it really is like a cursed piece of land. I hate to be extreme, but that's how I look at it. And to just make changes in there, to me, in the end, it's going to get back to the same thing. All right? So Just Leadership's goal is obviously, y'all know, is to open up state-of-the-art facilities. I think this will help everyone by having the necessary programs there, so when the inmates or the detainees, or however you call them, characterize them, are transferred, they can see that things are being done to make things safer for not just them, but also for the officers. That's another very important component. Nobody should go in there and feel like they're going to lose their life today. I'm saying the way you change that is you got to change the relationship. The way you say that, it got to be respect. And I'm saying the way you do that is through the training. I think that would be good if you have a lot of training to both. You know what I'm saying? So I just wanted to say that. Thank you. Have a great day.
Thank you, Mr. Coleman. So the next scheduled meeting is June 12th, 2018, in this room at 9 o'clock. Okay. Can you come forward, please? Tell us who you are.
Good morning. My name is Victoria Phillips. I work at the Urban Justice Center Mental Health Project, and I'm also a member of the Jails Action Coalition. Very quickly, I would like to touch on a few things. Thank you, Dr. Cohen, for your pushback and your constant questions to the healthcare staff today and DOC. I'm very disgusted that 3 people sit on this board with the title of doctor, yet only one of them refused to vote on the ESH today. 2 of y'all, and I've been to your community uptown, and people think of you very highly in your community, but yet y'all put forth certain variances today and additions, and not one of you with the doctor title even spoke about one-to-ones when you talk about shackling people. And then y'all also spoke about people being allowed to be in shackles, because it's not restraints, they're actual shackles, when they are at risk of doing harm to themselves. How can you carry the title of a doctor and agree to put people in shackles? First of all. Second of all, let me be clear, and I've been threatened to not say this on the record before, but I have never been scared of bullies with badges, whether it's by NYPD or the Department of Corrections. So let me be clear. If everybody wants to truly stop the violence on the island, you have to start with your uniformed officers first. Many of those people are a part of organized crime. Many of those people are a part of the gangs that we speak about quite often in this room and in City Council. And also, I wanted to address, DOC was at City Hall last week, and they went on the record once again stating how people in certain housing units are still getting programming and stuff. Just last night, I won't name who it was, came to our Jails Action Coalition meeting from the community and reported how last week, Wednesday, they still could not produce all day for programming. This is something that needs to be addressed. Y'all need to stop overlooking it and deal with it. And as another thing, I'm going to finish my last thing was saying, as a person that works at the Urban Justice Center, I take offense to anybody attacking any of my interns that get up here and openly disclose their own personal experiences. Cobra, I'm talking to you. And I also want to really remind you all that 41% of that 340,000 was mental health people, was people diagnosed with a mental health concern. And we need to clearly follow up with them. And it's not on an officer to say somebody refused. It is on mental health staff to directly go to the client, their patient, and make sure that they're refusing care and to find out why. Have a blessed day.
Thank you. We're now adjourned. Thanks very much.